Hello, my name is João Madureira and I'm a neuroradiologist at Hospital Santa Maria Lisbon and a former fellow at NeuroIBCETR. In this series of videos, we will cover the main topics regarding radial access neurointerventions and how this fits the overall history of ENR. In this section, we review the main advantages and fears regarding the use of radial access for neurointervention procedures. Radial access has several advantages compared to the more conventional femoral access, namely those related to a better access profile with less puncture site complications. It's also better suited when there is a high hemorrhagic risk, severe aortoiliac disease, and in more obese patients, since the radial artery is more superficial. It's also preferred by patients due to a faster recovery rate, less discomfort after the procedure, and earlier mobilization. And it's more cost efficient because there are less complications at the puncture site, earlier discharge, so the healthcare related costs are lower. So taking all of these into account, why are some centers so hesitant in starting radial access? Well, there are still some concerns regarding the technique in neurointervention, particularly due to the belief that the procedures are longer with higher radiation exposures and more neurovascular complications. There are other concerns, namely those related to radial arterial occlusion or spasm. However, these pitfalls can be overcome by practicing and being methodical in the approach. The introduction of the radial access in ENR benefits from the massive works already published in the cardiology area, such as the Matrix trial and the Rival study, which have shown that morbid mortality outcomes can be even better with radial access compared to the femoral approach. There is a lot of concern regarding an increase of stroke with radial access, but studies have not been consistent in their results, with larger cardiology studies, such as the Rival study, showing no difference compared to the femoral approach. In this same study, there was a statistical difference regarding hematoma and pseudoaneurysm formation, benefiting the radial approach, and technical parameters were similar between groups, except in the fluoroscopy time, with radial access being a little bit slower, albeit not clinically significant. However, this is only true that radial and femoral can be compared one to another, or radial access even better after practice. And studies have shown that there's a learning curve of 30 to 50 cases. After this, the procedure outcomes get better. And in this slide, for example, you can see that the results are in a study that have shown that with a higher volume of radial access in a center, the radiation doses reduce in a steady way. And this is also true in neurointervention. Notice this study that showed that before 30 procedures, the outcomes of the radial approach get better than the femoral. Radial access can result in faster procedures, less puncture time, less fluoroscopy time, and lower contrast use. So why go radial? Go radial to have a better access profile to improve patient comfort and get better cost efficiency rates. But this is only true with training, so don't give up after some procedures, because it gets better with practice. In the next section, we'll make a quick review of the upper limb anatomy, which is essential for these procedures. Thank you for your attention.